Good afternoon, everyone, and welcome. At this time, I'd like to acknowledge the presence of our own director, Dr. Rosman Adams, Director of PANCAP, Mr. Ivan Crookshank, Executive Director, Caribbean Vulnerable Communities Coalition, CVC, Mr. Jason Shepard, Senior Program Officer, Caribbean Regional Network of People Living with HIV and AIDS, CRN+, Ms. Veronica Sinak, Consultant responsible for the PANCAP Social Contracting Toolkit. PANCAP members and stakeholders or development partners, other officials of the CARICOM Secretariat, members of the media, ladies and gentlemen, welcome. Today, PANCAP will officially launch its Toolkit for Social Contracting. And thank you for taking the time to join us, and this demonstrates your commitment to the region's HIV response. Before we begin, I'd like to share a few housekeeping tips with you. Firstly, your mics are muted, but there will be a question and answer segment, and that will be following our final speaker. I'll ask you to please click on the raised hand icon on the GoToWebinar control panel, and your microphone will be unmuted and you will be able to ask your questions. There's also the chat option where you can post your questions via the chat box, but we haven't seen many of our members and partners face to face for quite some time. So I want to encourage you to unmute your microphones and turn on your webcams as well so we can have that interaction while you ask your questions. Permit me to share my screen while I introduce our first speaker. So welcome again, everyone. And we have quite a packed program for you this afternoon. So I'll go right into introducing our first speaker. Dr. Rosman Adams is the director of PANCAP, as I stated before. And Dr. Adams will enlighten us on the purpose of the PANCAP Toolkit for Social Contracting. He will also speak on the value that this toolkit will bring to the region's HIV response. Dr. Adams, welcome.
Thank you very much, Timothy. Good afternoon, everyone. It is indeed a pleasure to see so many of you here this afternoon at the launch of the PANCAP Toolkit for Social Contracting. As all of us know, or most of us know, that COVID-19 has been very disruptive to the work that we do in ensuring the continuity of care for HIV, STI, and other opportunistic diseases. 1 year into the pandemic, national programs, NGOs, and civil society organizations have been working non-stop to strategize to ensure the continuity of services for people living with HIV and other vulnerable groups. Despite these disruptions brought on by the ongoing pandemic and the challenges in the health system, we must commend everyone for ensuring that those who are really in need of care and receiving the care and treatment needed at this critical time. Also, the continuity of services are critical so that we maintain the gains made over the years in reducing new infections and decreasing AIDS-related deaths in the region. Over the years, civil society organizations and NGOs have played a central role in supporting national programs, in providing services for key populations and other vulnerable groups. When national programs may not have the capacity to reach, CSOs have been able to mobilize resources and to reach these communities. In many countries, CSOs offer services to key populations and groups that otherwise will not have access to or have difficulties accessing services. A harmonious relationship amongst all partners is needed now more than ever. We need all hands on board to work strategically if we are to end the AIDS epidemic by 2030. And this is further compounded by the difficulties that we're encountering now with COVID-19. At the end of 2019, the Caribbean was not on track to achieve the UNAIDS 90-90-90 testing and treatment targets. By then, only 77% of people living with HIV in the Caribbean knew their status. 81% of diagnosed people were on treatment, and 80% of those on antiretroviral therapy were virally suppressed. Also, the data showed that key populations accounted for just over 60% of the new infections in the region. A survey conducted by PANCAP and PAHO showed that during 2020, facility and community-based HIV testing services reduced in 2/3, almost 69% of countries due to COVID-19. Another survey conducted by PANCAP showed that the disruptions were principally in HIV testing, prevention services, and services for key populations. With the disruptions caused by the pandemic and the missed targets, we have no choice than to act by accelerating our work by ensuring that testing and prevention services are continued and sustained. People are linked and retained in care and are virally suppressed. This will not and cannot be achieved unless we all work together towards this common goal. It is therefore against this background that PANCAP, along with key partners, have been working to promote social contracting in the region. Social contracting is a process by which government funds are used to support non-governmental entities such as civil society organizations to provide services. It involves a legally binding agreement between government and CSOs where the government agrees to pay CSOs for service delivery and CSOs agree to provide specific deliverables. Social contracting mechanisms serve as an avenue through which critical HIV services provided by CSOs at key populations can be sustained. In some of our countries, government do support CSOs. In other cases, CSOs mobilize their own resources from external donors. And in some cases, there is the mixed approach where CSOs mobilize their resources and do get some level of support from government. Our approach to social contracting is to ensure that national programs are sustained and that countries are making the relevant investments to respond to the HIV epidemic. Effective rollout of social contracting will require planning, ongoing advocacy, and collaboration between governments and CSOs as they build partnership for the delivery of HIV services. This partnership must be grounded in trust, transparency, accountability, and efficiency geared towards assisting government to implement its policies and support the achievement of national goals as outlined in their national strategic plans. The toolkit presents a step-by-step approach to guide decision makers in the implementation of social contracting. The toolkit is built on the principles of commitment, meaningful participation of all partners, transparency, fairness and equity, accountability, and independence. It will allow countries to assess where they are along the process and to provide guidance to move to the next steps of implementation. For countries that are at the initial stages or are just discussing social contracting, the toolkit will provide guidance in the critical areas for considerations such as legal and regulatory framework, costing, and standardized contractual mechanism that must be put in place to support social contracting. We recognize that there will not be an ideal time to put social contracting in place, and we cannot wait for this time because this time will not come. The reality is we have to start and we have to put things in place now. The toolkit comes at a perfect time when we have seen CSOs going the extra mile to ensure that the disruptions and the impact of COVID-19 on their lives and the livelihood of people living with HIV and key populations are minimized. Governments must continue to work with CSOs to develop, finalize, and approve country roadmaps for social contracting. They must commit to implementing activities outlined in these roadmaps, including revision of current legislative and normative documents and to set aside funding to support social contracting for CSOs services for key populations. Donors are encouraged to support capacity development of governments and CSOs to implement social contracting and to provide the technical assistance needed for implementation. CSOs must advocate for funding for government social contracting and must cooperate with governments to implement and ensure accountability. We are all excited to launch this toolkit to be used in our region. Furthermore, PANCAP will continue to advocate and to support governments and CSOs along the process. Social contracting has been shown to be effective and to be the formal link between the two sectors to provide the desirable results that we are all working towards. We look forward to working with all of you as we move forward and advance this initiative in the region. I thank every one of you for your participation today. Special thanks to the consultant who will present this afternoon on the toolkit, to the PCU team who has been working along the way as we develop this toolkit, and also to the panelists who will be speaking this afternoon, and all of you from national programs and from governments. And we hope that as we launch this toolkit, it will be used in our region, and that it will be, a very important document for CSOs and government to reference as we move social contracting as a mechanism for financing and sustainability of the HIV program in our region. I thank you very much. Timothy, back over to you.
Thank you so much, Dr. Rosamond Adams. As I mentioned, Dr. Adams is the director of PANCAP, and Dr. Adams really did a great job of outlining how this toolkit will help governments and CSOs form strategic partnerships that will benefit the region's HIV response. Thank you again, Rosamond. Before I introduce our next speaker, I just want to quickly acknowledge some of our key stakeholders that have joined us. We really appreciate you taking the time to be with us this afternoon for the launch. I just want to quickly acknowledge Ms. Valerie Wilson, and she's the director of the Caribbean Med Labs Foundation. I also see we have Mr. Enrique Romero, and he's responsible for the HIV response in Belize. Thank you, Enrique, for joining us. And we have some officials from the CARICOM Secretariat that I'm happy to see have joined us this afternoon. I want to quickly acknowledge Ms. Shelon Boville, Ms. Corville David, and our own Mr. Colin Curtin has also joined us this afternoon. Thank you all. So I'll go straight into introducing our second speaker. And this speaker is no stranger to the region's HIV response. Mr. Ivan Crookshank is the Executive Director of the Caribbean Vulnerable Communities Coalition based in Jamaica. And Ivan will now highlight the importance of this toolkit to our most vulnerable populations. Thanks so much for joining us, Ivan.
Thank you very much, Timothy. And thank you to all the participants. And I'm very excited about the launch of this toolkit. I think the launch of this toolkit signals a significant shift on the journey particularly for us in the civil society community. It marks a significant part of the journey that we have been pursuing around how can we get civil society to be more firmly grounded in our regional, national responses. And we see social contracting and the approach to social contracting as central to that effort. So for us at CVC and in the broader civil society movement, we're excited about social contracting and what it offers, because we see social contracting as moving us beyond the perception that we have long held about how governments deal with the issues of civil society using a sort of handout approach. And social contracting allows us to be able to define more clearly what the value that civil society can bring to the table and the relationships that can be established between government and civil society. So we see social contracting as a fundamental change in the approach of government concerning the role of civil society. And this approach is one in which civil society is viewed as a third independent force in public policy making and service delivery. We also see it as an opportunity in which national governments can outsource arrangements to deliver services and government activities through civil society using what we commonly recognize and acknowledge as a buyer-seller relationship. In this particular approach, it allows governments to bring civil society organizations into the service mix, providing them with funding, but also with the responsibility for the delivery of some of the services that are traditionally delivered by the government. This approach allows for governmental or social service goals of the state to be delivered through essentially market mechanisms on the basis of competitive tendering and service contracts. So what does civil society organizations bring to the table that makes us such a unique participant in this process? And we're talking about a process in the context of responding to achieving our 90-90-90 goals. First of all, civil society brings local knowledge to the process. We bring technical expertise. We bring a form of social capital, which is oftentimes missing in government and community relations. And we also are bringing participatory approaches to solving community problems to our national HIV responses. Historically, many of you who would have come from civil society would have known that civil society organizations generally start from community actors just trying to respond to challenges that they saw on the ground and determining how can we address these challenges using our own methods and our own strategies. Additionally, we believe that civil society organizations have some additional values that they can bring to this particular process. Through social contracting, civil society organizations can bring more coherently the voice of marginalized communities and the stakeholders to national conversations and national responses. By engagement in social contracting, we also believe that the government and civil society actors through these relationships can bring greater transparency, accountability, and good governance to the delivery of HIV services, as well as promoting local ownership of national HIV responses. We're also confident that social contracting and what it can deliver will allow civil society organizations to bring innovative ideas and solutions to solve local problems that affect key population groups in particular. Through social contracting, we believe that there is the opportunity for strengthening and bringing to bear the leverage of communities on development programs that can generate social capital at the community level, targeting assistance and responses where they're most needed, while bringing to bear the professional expertise, whether it is from governments or from the community, to increase capacity, especially where we recognize that government capacity to deliver on some of the national goals are already limited. Through social contracting, we believe that civil society organizations have a significant number of advantages in bringing us closer to the 90-90-90 targets. Civil society organizations, through social contracts, can push the envelopes in ways that governments can't, particularly in unfavorable environments where stigma and discrimination is prevalent. Civil society organizations, from our own experience, and the literature is clear on this, is often better connected with the communities where the challenges lie. Members of civil society organizations often come from these communities, better understand the ways that the communities operate, and therefore can bring to bear a better understanding on the delivery of healthcare services to especially inadequately served populations. This implementation of the social contracting toolkit for us is significant because it offers a significant opportunity for civil society organizations and NGOs to offer value for money in our national HIV responses. This is largely a consequence of the fact that to some degree, the cost of delivering services through community workers is oftentimes less because we are lower level and we have less significant overhead costs. Some of that is debatable, and we actually have to really look at what the cost of delivering service is among civil society organizations. But we think that civil society organizations have the capacity to deliver services at less cost than obtained currently. We also are confident that civil society actors have a natural empathy for the people to whom these services are delivered. And that is something that cannot be understated, because that level of empathy allows us to be able to better connect with and engage with our communities, particularly when we're dealing with interventions designed to achieve behavior change. The other thing that we also are confident around is that there is a higher level of customer service quality that oftentimes come with community engagement with some of these responses that we are seeing on the ground. And that is because they're driven by the communities themselves. The members of the community understand the gaps, the issues, the persona, just the general disposition of the constituencies that we're providing services to. And therefore, we have the ability to provide an enhanced level of service to the communities that we are trying to reach, especially in the context where we said that we're addressing significant health barriers. We're excited about the social contracting toolkit because we believe that through social contracting, we, in our national responses, will be able to have an increased reach to our inadequately served populations. We will be able to use social contracting to expand the package of services that we can deliver. At the moment, even though, and I think Dr. Rosamond spoke earlier on to this particular issue around the fact that civil society organizations through this pandemic have continued to try and maintain the services and engagement with communities. We believe that social contracting does provide an opportunity for us to expand this package of service that we can deliver in times such as the period of COVID that we're going through new and innovative service models, packages of services that are more tailored to the needs of the constituencies, taking into account the shifting dynamics of the environment in which we are operating, to take us to our ultimate objective of increased retention in care and increased viral suppression among our constituencies. While we acknowledge that social contracting and the launch of this toolkit provides us with a golden opportunity, we recognize that there are some important issues for consideration. So we know that at national levels, There are some legal issues that have to be engaged with. So one of the questions that we will need to answer is, how will governments engage with civil society without appearing to be interfering with the operations of civil society organizations? We also know that one of the issues that we have to grapple with is just what mechanisms are used to select the entities that would participate in these social contracting arrangements. And from our point of view, we believe that there needs to be clearly defined and shared criteria for selecting entities. And these are things that at the country level, national actors will have to grapple with. Resources should also be allocated for clearly defined goals and priorities in line with national policies and public health needs as defined in national health strategies and in national budgets. So while we laud the implementation of social contracting, we believe that much work needs to be done to ensure that the resource allocation is aligned to what those national goals and those national budget imperatives are. So what is needed from government in this regard? We believe that in order for social contracting to work well, we believe that there needs to be a review of the legal framework. We also believe that there needs to be training and sensitization of our critical government actors to ensure that everybody is on the same page. So once we launch social contracting at the national level, that there will be a common understanding about what the government's intent is. We also, and I think Rosamond alluded to it earlier on, that there needs to be systems to ensure transparency and accountability for public spending are established to support the implementation of social contracting. While there is some activity and work that needs to be done at the level of government, we also appreciate that civil society organizations themselves need to undertake some activities to be able to make themselves ready to support social contracting if it is to be meaningful. So civil society organizations have to ensure that they are properly registered and have adequate governance arrangements to meet the criteria and commitments of social contracting. That will require strengthening of their internal capacity to implement activity, looking at what they do, ensuring that they align themselves to national strategic plans and national strategic priorities to ensure that they position themselves to embrace social contracting as an opportunity that is provided by governments, and that they assess themselves to ensure that they're ready to engage with national governments as they roll out social contracting. So all in all, we see the social contracting process as a critical tool to support addressing the HIV challenges across the region, and we also see it as a critical response mechanism to fund the civil society and to move us beyond the sort of ad hoc handout approach that has traditionally guided the civil society government engagement, and a way of strengthening the civil society response at national level. We are excited about this opportunity. We are excited about how the toolkit will be used by national actors. And I can indicate to you that from CVC and the civil society partners that we're working with, we will be working collaboratively with our national actors to ensure that social contracting is pushed, is promoted, and wherever possible, in every opportunity possible, be utilized as a significant tool to drive our national HIV responses moving forward. And so we look forward to the conversation today, and I look forward to us engaging further in this conversation. Thank you very much. Back to you, Timothy. Thank you.
Thank you, Mr. Ivan Crookshank, Executive Director of the Caribbean Vulnerable Communities Coalition. And Ivan, very poignant remarks as usual. And thank you for reminding us that civil society is the heart and the backbone of the region's HIV response. And especially we want to thank you for you and the team from CBC for endorsing the PANCAP toolkit for social contracting. Of course, your endorsement, your support is critical to this process. Before I introduce our next speaker, I just want to again quickly acknowledge some of our key stakeholders that have joined us this afternoon. Of course, we want to acknowledge your support. A very critical and key stakeholder, Ms. Joan Didier. Thank you so much for joining us. I'm very pleased to see we have a very large contingent of our key stakeholders from Suriname, Mr. Lucien Govard, Ms. Monique Haltian, and Ms. Tanya Campbell Corrigan from Suriname. Thank you, these critical players in the civil society in Suriname. I also want to acknowledge Ms. Renata Langlis from CRN Plus, another key stakeholder. And I'm very, very pleased to see we have one of our PANCAP champions, Ms. Sandra Granger, has also joined us. So thank you all. We really appreciate you taking the time out to be with us this afternoon. I just wanted to quickly acknowledge those key stakeholders. Today marks the culmination of a lot of hard work from our next speaker. She has endured many sleepless nights to bring us to this point where we can actually share the toolkit with the region. Veronica Sinak is the consultant responsible for the PANCAP toolkit on social contracting, and I'll now invite her to highlight some of the critical components of the toolkit. Veronica, thanks for joining us.
Thank you very much, Timothy, and thank you to everyone who is attending. I want to specifically mention the team at CARICOM who has been very helpful and patient in both in terms of ensuring that the process is continuing, but also in assisting in getting information and support from the countries that we did. Specifically, I want to say that he's there as a participant, but Lucien Govard from Suriname has been one of the critical players in designing this social contracting toolkit. So thank you very much, Lucien. This is a sort of a joint presentation by Lucien and myself because of his participation in the toolkit. I think everyone can see my screen now. So just so that we have enough time to take questions, and I hope that we have a lot of participation from the OECS countries. This is an issue that is very actively being considered at the level of the OECS by many countries, and I hope that, as both Dr. Adams and Ivan pointed out, that this toolkit is going to be a useful guiding document in determining some of those issues. So just quickly, why social contracting? And this some of the issues that we address. So Dr. Adams spoke specifically about COVID-19 and the implications for COVID-19. The UE Health Economics Unit utilizing World Bank data have indicated that there's been a contraction of the Caribbean GDP and worldwide GDP, but certainly increasing of the Caribbean, which has a projected decrease of 5.2%. That's a significant hit to our economies, and so whatever decisions we take has to be both strategic and sustainable. We know that we also have dwindling donor resources that we usually relied on to fund the HIV response, and particularly these donor resources have been the backbone of our prevention efforts. Also true, and Ivan mentioned it, and I don't have to go into the details, but quite very clearly set out the comparative advantage that CSOs have in reaching key populations, in particular the vulnerable groups, on all the pillars of the treatment cascade: prevention, testing, and treatment. Right. So another issue, and part of the rationale for social contracting, is that decrease in funding requires or transitioning out of global fund or donor funding requires providing support to the design and implementation of sustainable responses, including and particularly funding mechanisms so that we can continue to have essential services provided by civil society and community-based organizations. I would point out that this system of social contracting is sort of a key feature in many other countries, particularly developed world. In Canada, you have the Public Health Agency of Canada that provides a significant amount of support for a lot of the key HIV NGOs and human rights NGOs in the region, and other governments have the same level of response. Social contracting also supports the role that government has in providing health services to the country, and it can greatly enhance the country's overall response to not just HIV, but TB, etc. It is a methodology to implement services more efficiently. Ivan also alluded to that civil society tends to operate at, in many cases, not all cases, at lower cost. There's a high level of reach among civil society because of the trust elements of the persons who are going to be reached. And CSOs target services specific populations. So when the Global Fund talks about differentiated service delivery, a model that focuses on organizations who are dealing with individual communities and sometimes across the board, but they have their communities and they could reach their communities more successfully. So you don't have to train and retrain people in government to try to do the same thing that CSO organizations are doing. Social contracting is therefore an advantageous option in any country that is seeking to build and improve its health system. It promotes the sustainability of vital services, and it provides civil society access to alternative funding sources. Essentially, governments and other domestic sources are the most logical and sometimes the only option for maintaining effective and comprehensive responses and strengthening systems and procedures to maintain those usually neglected programs such as prevention for key and vulnerable populations. Dr. Adams also alluded to that social contracting has been shown to be an effective way to formally link the two sectors. So in countries, I mentioned Canada, but certainly in Latin America, in Mexico, for example, we have an example in the Dominican Republic. We have other examples in Eastern Europe where social contracting models are well defined and well established, and they are a central piece of government's response to various issues affecting health, not just HIV. So what is social contracting? It's a term that has caused some confusion in certain cases, particularly in non-English speakers, but essentially I just like to quote William Shakespeare, what's in a name? That which we call a rose by any other name would smell as sweet. So let us just focus on what the dynamics of social contracting is, and if we have a difficulty with the name and whatnot, then that's something that at the country level that could be managed. So before we go into the some of the definition, social contracting, there are concepts that refer to contracting in models and contracting out models. In a contracting in model, CSOs work within the existing system to strengthen structures and programs. And we have that happening. A lot of donor funding, global funding has gone from national aid program to civil society to do things. But it's an ad hoc situation, not necessarily a formal, structured, performance-based relationship. In the contracting out model, which is what we are considering, CSOs are given contracts through competitive or direct bids to provide a particular service, and I will add to that, or achieve a particular outcome. In the toolkit, the recommendation, we reference two definitions of social contracting, and that is one by the designers of the social contracting diagnostic tool together with the Global Fund, which is a process by which government resources are used to fund entities that are not part of government, referred to as civil society organizations, to provide services. The other definition is that it is a financing option by which governments finance programs, interventions, and other activities implemented by social actors. I think both say the same thing. But the definition that you will see reference in a toolkit as the definition is a process by which government's resources are used to fund entities which are not part of government, called CSOs. And CSOs is a wide definition, so it also includes to some extent the private sector, to provide health services which the government has a responsibility to provide in order to assure the health of its citizenry. That concept, that it is part of government's obligation to provide those services, also is a guiding principle in terms of the rationale for allocating of funds. This is not government allocating funds to or separate funds to something that is not a concern for government. All of the services provided on the contract through a social contracting mechanism features and contributes very much to government's own obligations, to government's own outcomes in terms of the health of people. And so it has to be viewed as simply another mechanism or a more efficient mechanism to reach persons that government has an obligation to reach. The features of a social contracting model is that it has to include a legally binding agreement in which the government agrees to pay a CSO for services rendered. And the CSO agrees to provide certain deliverables in exchange, either services provided or health outcomes reached. And that's where the opportunity is for ensuring that you are actually achieving the health needs in accordance with not just your national strategic plan for HIV, but also your national health strategy. So the state, either through central or local authorities, therefore delegates the provision of social services to private entities and pays for this service. The state keeps its role in funding, in the control of spending, in the control of the quality of the services provided, monitoring and evaluation, and overall planning and coordination. So really and truly, it is a performance-based issue. So the key structural elements of social contracting are a legal framework that facilitates CSOs' work on the targeted diseases, whichever issue that you're addressing. We are talking about HIV in the toolkit more directly. There will be references to TB because of many countries have joined HIV-TB responses. A funded mechanism that facilitates community monitoring of the disease response. A clearly defined role for CSOs with targets and budgets in disease-specific strategic plans and costed action plans. And an existing contracting mechanism or system to provide both governments and CSOs with the tools needed for the work to be done effectively, and that can be reported on both programmatically and financially to all partners' satisfaction. So these are things that will not come unnecessary elements, and a lot of planning and organization and development work has to go in to do that. We will see that many countries actually do have some processes already in place. It is formal and structured in a more advanced way in different countries. But the social contracting process really will set out, and Ivan said it really provides a justification for this new financing option, but it also provides a justification for government to ensure that it's meeting its goals and targets in terms of health in a structured manner. And therefore, there's a lot of interface at the monitoring and evaluation level between and quality assurance level between CSOs and government. So the development of the toolkit was preceded by a review of what are the existing examples of social contracting at various stages, either at the initiation stage or some level of advanced stage in the countries in the Caribbean. So we did a review, and Lucien was exceedingly helpful in that regard. We did a review in Barbados, Belize, Guyana, Jamaica, and we added on Suriname because Suriname had just recently concluded its assessments for initiating social contracting and had some very good processes ongoing. So those countries were reviewed. And I will just pray see some of the findings that we
Okay, unfortunately, we're experiencing some technical difficulties with Veronica's presentation. But while we wait for her to just correct that problem, I just want to quickly again acknowledge some of our critical stakeholders that have provided their support and joined us this afternoon for our launch. I want to acknowledge especially Ms. Delcora Williams, and she's the program manager for HIV and AIDS in Antigua and Barbuda. We also are very privileged to have with us Ms. Carmen Gonzalez from the Global Fund. I also want to acknowledge Ms. Donna de Costa Martinez, and she is the co-chair of the Caribbean Vulnerable Communities Coalition. And we also have some other critical members of the civil society response, Ms. Alexandrina Wong. So again, I just want to quickly acknowledge some of our key stakeholders. And again, thank you for joining us and providing your support this afternoon. I don't think we have Veronica back as yet. So I'll quickly go to our next presenter or next speaker. And Veronica will probably join us after our next speaker. All right, so our next speaker has a unique perspective on social contracting to share with us. Mr. Jason Shepard is the Senior Program Officer for the Caribbean Regional Network of People Living with HIV/AIDS at CRN+. And Jason has worked closely with a team implementing social contracting in Guyana. Jason, thanks for joining us and sharing your firsthand knowledge of social contracting.
Thank you very much, Timothy, and good afternoon to everyone. All right, listening to some of my colleagues and partners across the region in terms of their views and their highlight on social contracting, I would want to take this opportunity to express from the Caribbean Regional Network of People Living with HIV and AIDS, CRN+, that we are happy to be a part of this process and fully support this social contracting toolkit. And as Timothy has highlighted, I've had the opportunity to work closely with NAPS in Guyana and SHOPS Plus from the US in order to support the implementation of Guyana's social contracting back in 2019. I've had the opportunity to be there firsthand and to work closely with some of the CSOs and to manage that process and to work closely in providing technical support with the NAPS so that they can be able to better manage and better approach social contracting in the next round. CRN Plus shares the view, as so many of our partners have said earlier, that social contracting is a sustainability strategy that governments need to embark on. CSOs have played a critical role in addressing areas such as HIV, sexual and reproductive health, TB, and malaria, carrying out tasks that government services can find difficult to implement. For example, such as flexible timing of HIV services. We know that not everyone is able to get to a clinic or get to a health center during the daytime because they work. So we found that CSOs have been able to take on that task and open HIV services at a later date, and even some care and support services. Echoing some of the sentiments of Ivan from CVC, so many activities at national level would be better implemented and population served using a combination of government health and other services and civil society organizations. With the decrease of investment from external funders, the governments need to improve and or increase working with CSOs with the core objective of meeting the national targets. So for us to clearly understand, or for us to be reminded, as so many of us working in the field understand this, it is very important for countries to assess mechanisms that are put in place to determine whether they meet particular needs that will sustain key services such as HIV and general health. Social contracting, being that sort of mechanism, really offers the opportunity to build greater governance, accountability, and partnership between national governments and CSOs. As highlighted by one of the previous presenters, we need to look at both ends of the stick. We need to not only advocate for governments to implement social contracting and to work closely with CSOs, but we also need to look at CSOs' capability for implementing social contracts, for being able to be accountable, being able to manage not just finances, but also manage relationships with government. Social contracting mechanisms are promising options for governments to fund their disease response efficiently and effectively. Numerous examples of successful mechanisms, including Belize, Dominican Republic, and Guyana, already exist, where civil society groups have signed contracts with government entities to deliver critical HIV services. Being a part of CRN Plus, which is a CSO, and looking at so many other CSOs that CRN Plus has worked with across the region, right? CSOs have been able to extend and expand the reach of government-led health systems, adding value to HIV prevention efforts and supporting persons living with HIV, especially in adherence and retention of services. And Ivan mentioned the 1990 targets, of course, which now that we're in 2021, we're now looking at revised targets. It is important, especially for adherence and retention in services with people living with HIV. And as communities at national levels, even at global levels, we need to utilize as much support as possible. And if that means government and CSOs working closer together, improving their working relationship, and if this is to be done through social contracting, and we have such guidance tools as this social contracting toolkit, then we have to be able to find that common ground as to how we can make this work. The benefits that CSO service delivery provides to national governments are essential to any HIV response, including CSO's unique role in reaching vulnerable and marginalized persons impacted by HIV. The social contracting concept is based on the premise that civil society groups often can provide certain essential services more effectively and efficiently than some governments or other sectors, including in areas that have infrequently, if ever, received some domestic support. Looking at all that we've discussed today and taking into account everything that we know over the years of our experience in terms of CSO work, in terms of supporting government work, we know that when we look at social contracting, one of the key things of social contracting is that it is a financing option by which governments are able to finance programs, interventions, and other activities implemented by civil society actors. This option, mind you, is not the only option, but this option could help prevent reductions and disruptions in targeted services for key and vulnerable populations, in particularly and ideally contribute to a more rapidly expanding effective HIV response. So, taking this opportunity to bring some remarks from CRN Plus, I would like to end our remarks by saying, simply put, we need basic agreements about how we can better offer services to populations most at need and how we can improve working with the government in not only HIV services, but additional services that can reach underserved populations. So CRN Plus fully supports this social contracting toolkit, and we look forward to not only working with PANCAP, but also working with national AIDS programs at national level, and also working with our partners such as CVC and other partners across the region. Thank you.
Thank you very much, Mr. Jason Shepard. And again, he is a senior program officer for the Caribbean Regional Network of People Living with HIV/AIDS at CRN Plus. And especially thank you, Jason, for highlighting that people living with and affected by HIV are the center of making social contracting a success in the region. Veronica has rejoined us. She's still experiencing some technical difficulties, but Veronica, can you hear me?
Yes, thank you, Timothy. Can you hear me?
Yes, we can hear you clearly. So I'll now
All right.
I'll share my screen so we can see your PowerPoint presentation.
All right, thank you so much. Okay, could you go to the next slide?
Just one moment. Just one moment. Let me just.
Sure.
Okay. There you go.
Okay, thank you, Timothy. Okay, I know we've lost some time. I apologize. My internet seems to be troublesome today. However, I'll try to go through as quickly as I can. And this was a slide, I think, when I went off that I was referring to the findings from the review process done in Barbados, Belize, Guyana, Jamaica, and Suriname. And these are the 4 common challenges that we found across the countries. That, you know, and participation and buying by all relevant stakeholders, where that was an issue because in some cases social contracting was not necessarily pushed by domestic, or it wasn't a locally owned process. It was if you want to call it, introduced and pushed by outside entities, usually donors. And so sometimes we found that in some cases there was a pushback against that. In other countries that were further along the spectrum, there was a lack of familiarity with financial and administrative processes and regulations that govern access to domestic funds, and designing and doing that process, understanding the budget process is an issue. Some countries that recently engaged in social contracting in Guyana, that was one of the challenges in the beginning of the process. Preparedness for implementation in terms of clear processes, templates, available budget guidelines, etc. That's something that needs to be detailed and fleshed out in a much more significant way for most of the countries. And the availability of dedicated staff for implementation and monitoring. Still an issue in some of the countries implementing social contracting, or even those considering implementing social contracting, in terms of where persons like that are going to sit. Next slide. Next slide, Timothy.
We're at key considerations.
Oh, sorry.
Yes, it's up.
I
Key considerations.
yeah, thank you. So key considerations that needs to be taken, and I think most of the speakers have already said that there has to be country ownership on the part of both government and CSOs. Without that, you cannot really, or the process will just be stymied. It will take a long time. So the buy-in is rather important. It's moving the whole issue from the idea into a reality. A lot of delays for many countries stems from the lack of applicable rules and processes that play a part in social contracting, particularly national procurement rules and regulations and government budget processes. So from the part of government, while these are well understood, the impact on the overall procurement and contracting process is not very clear. So, and that needs to be managed and mitigated. So for example, government budgets go in at a certain time, and so they need to be aligned with your call for proposals for social contracting needs to be aligned with that, etc. But it's all dependent on the financing option that is selected by the country. Generally, the more prepared a country is for implementation in terms of clarifying the processes, creating specific templates and guidelines, ensures greater transparency, comprehension of the process by all stakeholders, and mitigates delays. And then social contracting, and we've said that, the principles of transparency, accountability, and shared responsibility. We found that regardless of the model, however, both the relative newness and the nexus between social contracting and continued service delivery to key populations requires a dedicated effort to ensure its success. And by all, CSOs and government. Next slide. So the lessons was that CSO readiness needs to be given due consideration, as their comparative advantage is a critical element to enable continued service delivery. Capacity building is required for both governments and CSOs. Capacity in terms of costing, capacity in terms of budget review processes, capacity in terms of what we considered a readiness paradox for CSOs in terms of the capacity to retain key people, one, and persons with knowledge of processes, those persons who have been trained. Establishing and communicating clear guidelines that will serve to govern the social contracting implementation will facilitate smoother implementation. We noted that this should not be overly burdensome so as to defeat their purpose. Barbados was an excellent example of that, where they have, since 2011, simplified their processes so that the process, the application to the government is clear, the contracts are clear, it is simply written so that persons can understand, and there are clear timelines for every stage of the process. The model for social contracting that the country will implement should take into consideration the country's history in working with CSOs and lessons learned from existing systems. This could create strategic efficiencies towards establishing the mechanism. So we found, for example, good examples in very good existing mechanisms. So Barbados is one. Belize has not exactly social contracting, but contracting mechanisms between government and CSOs through the National Health Insurance that have built-in accountability procedures and transparency procedures that can be adapted. So in doing the analysis, there are many existing processes and procedures that can be adapted to ensure that the efficiencies in establishing the system are done, and we don't have to reinvent the wheel. Next slide. So the recommendation for the process for development was shared responsibility, critical, ensure dialogue and consensus building precedes decision making. So, and it also goes to meaningful participation of CSOs. Jason, I'm highlighted it, that the key CSOs, persons with HIV, and key populations have to be included. That there needs to be ownership and trust, foundational elements of the relationship between government and CSOs. And where that trust does not exist, any government would be hard pressed to give, even on a contractual basis, to hand over funds to an entity that they do not either have a trust in terms of, one, their capacity or their ability to account for those funds. And that is some of the bottlenecks in moving the processes forward. Preparedness and partnerships, stakeholders to develop and communicate the necessary processes, tools, guidelines, and policies beforehand as much as possible. Government needs to not build the expectations too high for CSOs. CSOs need to make themselves more accountable, but at every stage of the process, there needs to be transparency and fairness in terms of how they're built, and that is promoted by having this, by ensuring preparedness and partnerships, readiness, build the necessary capacity in both government and CSOs to take part in a social contracting mechanism to ensure continued service delivery. So given what we found in terms of what exists in countries and where countries are and the recommendations, the toolkit was designed as a and I'll put a 4-stage process guided by the following principles and key conditions, which Dr. Adams mentioned as well when he spoke. So principles of commitment, shared responsibility, transparency, fairness. And fairness, I think we all understand it to be equity, not dealing with each other equally, but dealing with each other so that we are on an equal plane. Accountability, independence, it needs to be goal-oriented. We need to have goal-oriented arrangements, free and fair competition, and equal treatment of applications once we have built in for fairness and equity. So performance areas, which are conditions, grounding in a successful implementation would be trust between government and non-government actors, capacity of civil society to serve as implementers, robust assessment and monitoring systems, proportionate supervision and oversight. In other words, not undue and overburdensome supervision and oversight, but proportionate oversight, accountability mechanisms. It will come up quite often for all the parties involved, including government, high quality planning and communication by government actors on contracting processes. So the toolkit is designed a 4-stage process, and I don't have it in the presentation here, but each process has a sort of a precursor where we would describe what the section covers, what is the learning objective, and that is how does the toolkit contribute to decision making at the country level, what the process is involved, including options and examples, and inform the outcome of each stage of the process. So you can evaluate whether your process is responding to the questions or to the issues that you need to move to the next stage. So the 4 processes. Sorry, Timothy, I'm very bad at it. I forgot to ask you to. Yeah. Principles and conditions. Next slide. The key principles, which I just mentioned. Next slide. I went over it, Timothy, so I'll just go to the next slide. Next slide.
It's there, Veronica. Key principles.
Right. I spoke to it, so because of the time, I don't want to go over it again, so we can just go to the next slide. Right. Thank you. So the guide, the toolkit is separated into a 4-stage process. Next slide. Right. Into a 4-stage process. Stage 1 is what we define as a readiness assessment, and that is for countries who are, even countries who are already have implementing social contracting, but it's sort of a review of where you are and taking into account the principles. First aspect of stage 1 is securing the political will of government and CSOs. So that's political will and partnerships. Then conducting an assessment of the legal and regulatory framework, assessing the financing options that are either both existing and are available in the country, particularly the legal framework around financing as well. And at the end of the readiness assessment, we should be at a position where you could make what we determine to be an investment case. So sort of a rationale to inform the decision makers, principally government and actors outside of the health sector, mainly the Ministry of Finance, in terms of the benefits or cost benefit, however you want to have whatever we need to do to define and give the advantages of engaging in a social contracting model. Once and a decision has to be made at that point, then to move to the second stage, which is once a decision is made, is moved to the planning and preparation. And that planning and preparation process involves setting up an implementation committee. And the issues are not exactly step by step, but it can move as well. So that planning and implementation committee can actually be set up during the stage of readiness assessment. So it can go either way. But at planning and implementation, we would then look at the capacity assessments or strengthening of government and CSOs for management into implementation. This is the point where we do, and particularly for CSOs, strengthen their capacity and understanding of government review processes, government financing processes. In particular, there has to be an identification of services to be contracted, the nature of services to be contracted, the development of clear procedures and guidelines. And that's where you develop your contracting models, your tendering systems, develop your systems for ensuring that you have a free and transparent process for selection, developing it, not actually implementing it. And of course, developing your monitoring and evaluation framework. The other assessment that has to be done is a capacity assessment for the CSOs. Is that, I mentioned it earlier, is what is called a readiness paradox. And we put that in there because one of the findings from the review process was that over the years, between the PEPFAR grant and the Global Fund grant, a significant amount of capacity building has been done among civil society organizations. But there has also been a lot of movement in and out of civil society organizations. So that capacity has not been retained. And so some organizations are well poised to engage in social contracting, and some others, while they may have a history of a significant amount of work, no longer have that capacity within those organizations. So part of sustainability of social contracting has to be a process of a strategy to retain the capacity within civil society organizations going forward. Next slide. Stage 3 is the implementation process, and more details are provided later. It's really determining, actually getting into the implementation stage where we determine the purchaser of services, the provider of services, call for proposals is issued, and contracts are issued, monitoring is conducted, etc. And stage 4, I forgive the typo, stage 4 is the roadmap to sustainability, and that is a review process at the end of the initial stages of social contracting, determining whether ensuring that it is included in your as a model for implementation or model for interventions under your existing or new strategic plans. Determine whether there's a need to review or revise legislation and methodologies or decisions on scaling up the process. Next slide. I think, Timothy, you went way ahead. Come on. Right, stage 1, securing the political will of government and CSOs, which is part of the readiness assessment. So we mentioned before, continued engagement between government and CSOs. And that is because when you make the decision to go to social contracting, it really ought not to be outside influences. It is supposed to be a local agreement. So in some cases, we saw that governments have sort of pushed the process. Others, donors have pushed the process, or CSOs have pushed the process. If there is an agreement to go to social contracting, it really has to be a coordinated and partnership between government and CSOs in saying, yes, this is something that we would like to see happening, and what our various roles in promoting social contracting has to be, the advocacy that has to go in. And of course, we in the tool define some of the partners that you need to involve from earlier clock. Would it be your ministries of health, your Ministry of Finance, the budget office, since financing as a financing option there is relevant. Ministry with responsibility for civil society organizations, your CCMs at the national level, and of course, key CSO, key population organizations representing PL, HIV, etc. Which is why we recommend that a committee can be set up even at that stage. Next slide.
Veronica, we might need just to wrap up this bit, just to leave enough time for our question and answer segment. I know a lot of our participants have some burning questions, and I think a lot of what you're going to say will come out in the question and answer segment. So do you want me to go to that slide where we can quickly wrap up some of the 4-stage process?
Yeah.
Okay.
You had it before. Right, okay. So this is if you want to call it just the sort of the entire process in terms of what needs to be done. So the prioritization, well, the needs assessment will determine that prioritization analysis, the rationale, which is what we call the investment case, the justification that would come up after the readiness assessment has been completed, and all of the other planning things. Planning is the allocation of funds, so determining the financing model, developing the documentation, building the administrative capacity of government and CSOs, and then the implementation, the actual tendering process, selection, execution of contracts, and monitoring and evaluation. So, right, so that leaves us only 10 minutes for questions, and I will end there.
Okay, thank you very much, Veronica. And again, Veronica Sinak is the consultant responsible for the PANCAP Social Contracting Toolkit. So we have about 10 minutes left. I know a lot of our participants have some questions, and you can ask questions to the entire panel. So now, ladies and gentlemen, I want to encourage you to click the raised hand icon on your GoToWebinar control panel, and that's right next to your name on the panel. Please note there's also a chat function, but as I said earlier, we haven't seen each other face to face in quite some time. So I want to encourage you to unmute your microphones and click on your webcam so we can have that interaction. So just click the icon, the raised hand icon that is next to your name, and we'll be happy to answer your questions. I don't see any raised hands as yet, but I know a lot of our, especially our civil society stakeholders are here. I don't know if they want to go ahead and ask some questions. I see Ms. Donna de Costa Martinez, Ms. Joan Didier. And again, you can ask questions to the entire panel. All right, I see one person has put their hand up. Let me just, oh, and we have Ms. Corvell David. Let me just unmute your microphone. Corvell, you're self-muted, so you just need to unclick. You just need to click the icon with the microphone, Corvell. You're muted.
Thank you, Timothy, and good afternoon, colleagues. Thank you, Veronica, for such a detailed presentation. I wanted to ask a question regarding guidance for countries, recommendations, and the 4-stage process for implementing social contracting. And I noticed that stage 1 refers to the readiness assessment, and under stage 2, which is planning and preparation, under bullet 2, you referred to the conduct of capacity assessment or strengthening. I was wondering why not in phase 1? That you'd have done that capacity assessment in phase 1. Is there a specific reason?
Yeah, thanks, Corvell. That's a good question. The capacity assessment in phase 1 is a bit premature, simply because you have to determine whether or not you're moving forward and what the priorities are going to be. In terms of, and it also depends on a financing mechanism. So if you select a financing mechanism that is would expand to include, for example, organizations like that are larger and some are smaller and whatnot, then we have existing data on the capacity of CSOs. But if you want to expand it to other CSOs and something that's in the slide but I didn't get to, so we have in some cases CSOs operating at different levels, and you might want to have in your transparency and competitive section, you might either want to have an open competitive process, so that capacity assessment is going to be different if you decide to go that route. You may want to have pre-qualification with conditions. You might have CSOs operating, as I said, a high level, like say Bailey's Family Life Association, or JASL in Jamaica, as compared to another smaller entity. And then you might want to have, depending on the nature, organize a consortium approach. So Jamaica has the CSO network, Bailey's has a CSO hub, and so that is not, in terms of what you're going to do with them, is going to be different. So the assessment comes after you've made the decision, and when you have a little bit more, you're a little clearer in terms of what is going to be funded, what financing mechanism might be most appropriate in the circumstances, and what process you're going to do in terms of selecting CSOs. I hope that answers the question, Cavell.
Yes, it does. Thank you. And I really didn't look at it from that perspective, but thank you for this explanation. Thank you.
Sure. No problem.
Thank you, Corvell. Thank you, Veronica, for responding. We have another question from Mr. Michael D. Goulard, and he's from UNAIDS. Michael, you can go ahead and unmute your microphone.
Yes, good afternoon. Yes, I am Michel de Goulard. I am currently the UNAIDS country director for Guyana and Suriname, acting at the moment and not sure for how long. In both countries, we are working on developing social contracting. There are two things that I want to raise. One is that for now, at least, the countries that want to do social contracting are really relying on the Global Fund grants to provide support to social contracting. So that is something in terms of sustainability that we may need to look at. I'm not sure what is the experience in other countries, but that's what I'm seeing. The other aspect is what Jason has mentioned, is the role of the network of people living with HIV. And that's something that we are trying to address in countries where these networks at the national level are very weak, or basically do not exist for various reasons. So in terms of the capacity assessment, when it comes to the role of networks of PLHIV, which is essential in the social contracting approach, we have to almost start from scratch. So we need to provide more support to the countries at the community level to see what we can do to make sure that these networks at the country level can not only exist, but also play their full role in social contracting. So that is the challenge that we have.
Yeah, can I go ahead, Timothy?
Yes,
I just want to respond
Veronica.
to Michelle's 2 points. Michelle, I agree with you 100% on the second point. That is an issue because, and that's why we had we started a paradox. We have some essential CSOs who don't have the capacity. The capacity have gone. They haven't retained people, and some CSOs need to be rebuilt. And organization of persons living with HIV is certainly one of them. At least we build their capacity. And so countries have to consider that in that regard. But the way of doing it is, as I was explaining to Cavell, is that depending on the approach you take, so in terms of who is eligible, you could have a situation where, so Belize is a good example with the hub, and again, Jamaica too, what we call a consortia approach, where organizations are grouped or linked, the natural linkages that they have, and they build, we leverage that. So you want to include an PLHIV organization who doesn't have the capacity, but you design the bidding process or the selection process so that they can join with a stronger entity who can build their capacity, particularly in terms of accountability, these administrative issues, because they have the comparative advantage in terms of actual, in some of the delivery of the services, but they may not be able to fulfill their contractual, all of the contractual obligations from the administrative obligations. So that's these are options that's described in the toolkit. On the first issue that you mentioned, that some countries are using global fund resources, yes, not all. Barbados has from 2011 used government recurring expenditure to fund its social contracting, and there are other examples, but I think the global fund usage of resources is actually something that is may be beneficial in a sense that it allows countries like Guyana, for example, to develop it, tweak it, make the just necessary amendments, so it's run as a pilot, and thereafter it may be actually be something that's necessary even to build the investment case for Ghana so that the government can take it on. So that's something that has to be done. So the whole concept of social contracting is to transition out of donor funding, but the Global Fund agreeing to do that is also an opportunity for the countries to ensure that they get the processes right, that they get the funds to do the case, to do the investment case for social contracting, and have the information by way of a pilot to be able to strengthen whatever models that that the government decides to implement.
Okay, thank you very much, Veronica. We want to thank Michel Diguillard, the UNAIDS Country Director for Guyana and Suriname, for his question. I don't see any more hands up, so if there are no further questions, I think we can bring our launch to a close. And just to let you know, you will be receiving, as you can see on the slide that's up, you will receive the PANCAP toolkit for social contracting in an email shortly. It will also be available on the PANCAP website and all our social media platforms, as you can see on screen. And with that, ladies and gentlemen, we'd like to thank you for joining us to officially launch the PANCAP Social Contracting Toolkit. Again, I want to thank our panel, Dr. Rosamond Adams, Director, PANCAP, Mr. Ivan Crookshank, Executive Director, Caribbean Vulnerable Communities Coalition, Mr. Jason Shepard, Senior Program Officer, Caribbean Regional Network of People Living with HIV and AIDS, CRN+, and Ms. Veronica Sinak, Consultant responsible for the PANCAP Social Contracting Toolkit. Please remember to stay connected with the partnership on pancap.org. And our email is also on your screen in case if you have any further questions or any further clarifications about today's launch. And we invite you to like us on all our social media platforms as well. So once again, thank you everyone for joining us. We really appreciate the turnout, especially from our civil society or National AIDS Program managers and all our key development partners as well. Thank you very much for joining us, and please remember to stay safe. Thank you.